conducting various programs at state, zonal, national, and international levels. We see a problem, we discuss it, find a solution, raise awareness, and make it a reality. Just some information about what GAIMS exactly is. The Global Association of Indian Medical Students is a global organization representing the medical students all over the cross of Indian origin. It was created to provide a think tank that works to provide the highest possible standard of medical education to all Indian medical students to be the best in the world. It's a non-political association working with constantly engaging global medical academicians and educators in bringing efficient and quality education and abiding by government leadership to provide think tank suggestions to provide best healthcare to citizens of India and also of Indian origin all over the globe. And with immense pleasure, I provide warm welcome to Dr. SAVITHA Balaraman for our today's session where she is a speaker today. Some bio about her. Dr. Savitha was born in Madras, India, and is a graduate of the Madras Medical College, Dr. MGR Medical University, Tamil Nadu, India. Her internal medicine residency was completed at Wayne State University, Sinai Grace Hospital, and her fellowship training was completed at William Beaumont Hospital, Royal Oak. Dr. Balaraman has been practicing medical oncology since 2002 with a focus in genitourinary, colorectal, and breast cancer. She's the chair of the Research and Community Outreach wing for the AAPI, that is American Association of Physicians of Indian Origin, a national organization of more than 80,000 physicians. Furthermore, she's currently coordinating research initiatives across the nation for students interested in careers in healthcare through collaborations with the American Heart Association and ACS, that is American Cancer Society. She's board certified by in both medical oncology and internal medicine by American Board of Internal Medicine. Huge welcome, ma'am. Can we have some words of introduction from your side?
Hi. Good morning, everybody. A lovely weekend to you all. Words of introduction, I think you've given me enough. I'm just really happy to be playing a very small part in the future of medical care across the globe. Personally, I feel very privileged to have been of Indian origin. I think the way I look at it is India is my motherland and the United States is my fatherland. Sounds cliche, but for those of you who've gone overseas and set up a new home, it's when you look back, you'll realize how much your medical education and your pre-med education has shaped you as a person, as a physician, as a clinician, a researcher. I think physicians of Indian origin across the globe, but I can specifically speak to in the United States, are held in very high esteem because we bring together a very unique combination, a combination of the highest level of scientific accomplishment, intelligence, and competence with the potentially highest levels of empathy and compassion that I've seen amongst many physicians. So I'm so glad to be, again, a part of this endeavor. I think you guys are doing a phenomenal, guys and gals are doing a phenomenal job in furthering science and community outreach, which our country really, really badly needs. So without further ado, if I may, I'll start.
Sure, Mom, the stage is all yours.
Okay. So this is actually a vast topic I've been given, and I'm going to do my best to give you a general overview with some areas where I will do a deep dive. So today I've been asked to speak on the statistics of breast cancer, causes, risk factors, genetics, the oncology piece, which is the treatment piece, diagnosis. I don't know if I can cover all of these, but I'm going to do my best. And if we can, in the future, we can do more specific topics because breast cancer is such a heterogeneous disease that I don't think an hour is enough to cover all of these topics, but I will do my best, okay? Okay, and now how do I move this? I'm a little technologically challenged, if you can't tell already. There should be a better way to do this. Okay, great, I got it. So just wanted to give you an idea. This, there has been a tremendous amount of research that's been published from India in the Journal of Clinical Oncology, Global Oncology subscription. And if those of you who are interested, most of my data today has been compiled from the Journal of Clinical Oncology, from the Global Oncology piece. So this is just an overview of rates of cancers per 100,000 between males and females across different districts. And you can see across the entire nation, there is a significant prevalence of malignancy, but the malignancy rates seem to be highest in people with lowest socioeconomic strata. And that seems to be because of the lack of education regarding smoking, alcohol, and other risk factors. And we'll delve a little bit deeper into that. But the global burden of breast cancer is about 2.08 million out of 18 million cases. So in the globe, if you took all cancers, breast cancers would comprise about 11% of those cancers, but would comprise about 6.6% of all cancer-related deaths, which is an inordinate burden for the patient, the family, the society, and financially. In India, it is the #1 cause of death. In 2018, there were over 160,000 women who died of breast cancer. It accounts for nearly 30% of new cancer diagnoses among women. So it has now overcome cervical cancer and lung cancer. And it also accounts for over 11% of deaths in women due to cancer. When you look at the demographics, it is the most common cancer in women in most major cities, and it's the second most common in rural areas. I'm sorry about the typo. It's the second most common cancer in rural areas. Looking further into the burden of breast cancer, because I want you to understand the scope of this disease and how a small change in the needle can make a tremendous difference when we're talking about 1+ billion people. In the Global Cancer Conference in 2012, this was 8 years ago, India, the United States, and China accounted for more than 30% of the global breast cancer burden. In the Western countries, breast cancer incidence is going down, breast cancer mortality is going down. On the other hand, in India, the breast cancer incidence is going down. Mortality is kind of plateauing at this time because of better accessibility, but we could do a lot better with understanding how to prevent cancer, early detection, screening, genetics, etc. So when you look at India, there's an 11.54% increase in the incidence over the last 5 years, and nearly 14% increase in breast cancer-related mortality. That's huge. This is related to increasing urbanization, increasing westernization of the way of life, changes in lifestyle, food habits, etc. And this is a wonderful article for those of you who are interested. Look up Epidemiology of Breast Cancer in Indian Women by Dr. Malviya. It's an eye-opening article. The numbers are startling. 1 woman is diagnosed every 4 minutes with breast cancer. 1 woman dies every 13 minutes of breast cancer. There's an estimated 70 to 160,000 women dying of breast cancer. And India topped that list in 2012, and it continues to top that list. The burden of cancer is obviously inordinately distributed amongst the metropolitan cities because breast cancer, as I mentioned earlier, is more common in the urban population. There's definitely an increased incidence as opposed to cervical cancer where the incidence is going down. This behooves that we have a multidisciplinary approach to cancer. So promoting awareness, prevention, screening, and most importantly, accessibility and affordability to treatment. This is a chart that I wanted to put to show you the burden of breast, cervical, head and neck, stomach, lung cancer in male and females. And if you look at the breast cancer graph, Localized breast cancer is diagnosed in about 30% of women. 57% of women, however, are diagnosed with local regional cancer, and over 10% of women, and this changes depending on whether we're in the rural areas or in the urban areas, are diagnosed with metastatic disease in India. As you know, the survival curve is inversely proportional to the stage of the disease. So the earlier the stage, better the prognosis, later the stage, worse the prognosis. And cost of care is clearly associated with the stage of disease. So farther out in the disease we diagnose a patient, higher the cost. And we know a lot of men and women in India cannot afford the oncology financial burden. When you look at the epidemiology of the disease in India, it's a very interesting phenomenon. In the rest of the world, breast cancer peaks at about 60 to 71 years. In the United States, we say the average incidence is about 65 years. We are seeing younger women, but even today, average incidence of breast cancer or average age at diagnosis is 65. In India, on the other hand, majority of women who are diagnosed are premenopausal, and the average age of incidence is between 40 and 50. Why is that important? The younger you are, the more aggressive the disease tends to be. Younger women tend to have false negative mammograms because there's very dense breast tissue. So by the time a palpable mass is identified or other symptoms are picked up by the patient, it is usually locally advanced, if not metastatic. Also, India does not have a universal screening strategy of mammograms, so most women do not even get physical exams by their physicians. They don't do breast exams. They don't get mammograms, so you tend to diagnose them much later. For instance, in India, depending on the statistics you look at, stage 1 and 2 is between 10 to 30%. Stage 3 is 30 to 60%. Stage 4 is between 5 and 24%. Again, if you look between stage 3 and 4, you're talking close to 70% of patients being diagnosed with locally advanced or metastatic disease, which clearly portends a much poorer prognosis, much poorer survival curve. We talked about the incidence increasing globally, but the mortality is increasing in India as opposed to the West, where the mortality is decreasing. This, again, is an epidemiology curve that clearly shows that the age at diagnosis is moving to the younger population in India as opposed to the West, where it is in the ages of between 60 and 70. When you look at the ranking and rates of breast cancer, so the left column obviously is the city, R stands for rate, CR stands for crude rate, and AAR stands for adjusted rates. So the rates are very high in New Delhi, Mumbai, Chennai, Thiruvananthapuram, and then it goes down as you go to the rural areas. The problem, however, is in rural areas because of lack of education, lack of good healthcare, lack of screening techniques, these patients tend to be diagnosed in the more advanced stage. So there are a lot of areas where we can intervene and change the natural history of disease. This is another graph showing the 5-year distribution amongst various cancer registries in India across different cities and different metropolis. When you look at the causes of breast cancer, I think we need to spend a little bit of time because this is where we can actually teach women and men, because the family is an integral part of any preventive strategy in any society, more so in India. So women who breastfeed, and the longer they breastfeed, have a lower incidence of breast cancer. Women in the urban areas tend to have a higher incidence, higher BMI, lower physical activity, low parity. So women who have 4 or more children tend to have a lower incidence of breast cancer. And we know as the natural history of women in the workforce is evolving, women are tending to have fewer children, sometimes no children, and women also tend to have children later in their lives. And we know when age at first live childbirth is over the age of 30, that itself is an independent risk factor. If you look at the GAIL model, there are certain specific risk factors, including maternal family history, Age at Menarche, Age at Menopause, that talks about the exposure to estrogen in a woman's lifetime, and breastfeeding. Those are all important risk factors. Obviously, tobacco has clearly been identified as a risk factor. And in the northeast of India, that is one of the highest causes of breast cancer. Polycyclic hydrocarbons, which I know India is making a huge move to decrease the usage of polycyclic hydrocarbons, have been associated with an increased incidence of breast cancer. Alcohol, clearly in the Western world, has been associated with an increased incidence. So women who drink more than 5 glasses of alcohol, including wine, a week, have an increased incidence of breast cancer, because women tend to metabolize alcohol very differently. Today, if you look at the urban population of women, it has become a more of a norm rather than an exception for women to drink alcohol. So educating them that they do not metabolize, or we do not metabolize alcohol like men, and therefore our moderate rate of alcohol is very different than that of a male, is very important. Genetics is another area where we need to pay a lot of attention. So historically in India, people did not talk about cancer in the family. So a lot of people did not know their family history. Things are changing. A lot more openness has come about discussion of healthcare issues, including cancer. So understanding between 5 to 20% of cancers can either be part of a hereditary issue or associated with a specific gene like BRCA1, 2, etc. is important. This is pretty much the same slide talking about causes, but a couple of things I wanted to inform you was exposure to diethylstilbestrol has been associated with an increased incidence of breast cancer. Previous radiation therapy to the thorax. So if anybody had Hodgkin's or non-Hodgkin's lymphoma or thyroid cancer in their young age and they received mediastinal radiation before their breast buds formed, which is typically before the age of 20, their risk of breast cancer starts 8 to 10 years after radiation, because their breast buds were exposed to radiation. So they need to start mammograms, MRIs much earlier than an average risk woman. Combined estrogen and progesterone use. So oral contraceptive pills and hormone replacement therapy are directly associated with breast cancer. And this increased risk for breast cancer continues for up to 5 years after cessation of the oral contraceptive pill or the hormone replacement therapy. I hope this slide projects well. This slide is another slide from Journal of Clinical Oncology, Global Oncology. These are the genes associated with hereditary breast and ovarian cancer diagnosed in the Indian population. As you can see, the two common ones, the BRCA family, BRCA1 and 2, TP53, which is Li-Fraumeni syndrome, P10 mutation, CDH1, STK, CHEK2, ATM, PALB. These are all pretty classic mutations across the globe. They're also pretty standard in India with a few changes, and I will talk about the differences in the Indian population. As you can see, the top 5, 6 of them are high penetrance genes. So these have a higher propensity of causing not just breast cancer, but other cancers. Then you have the CHEK2, ATM, and PALB2 family, which are the moderate penetrance gene. And then you have the low penetrance gene. So the cancer risks associated with BRCA1 and BRCA2 are very important when you talk about history. It is very important that medical students, residents, fellows, family practice doctors get a very detailed history of cancer in the family. I can speak from my personal experience. A very simple question like, is there a family history of cancer, is usually met with, oh no, there's no family history of cancer in my family. Then I start out by asking, how many brothers and sisters do you have? Are they healthy? How about mom and dad? What kind of issues do they have? How about your grandparents, uncles, aunts, cousins, nieces, and nephews? All of a sudden, the answer goes from, oh, I forgot to mention, my cousin at 30 was diagnosed with colon cancer. She's doing fine. She's 55. Well, that's a very important history. It also behooves us to understand how many female family members there are in that particular family and how many family members there are in total. It is very common these days for one child or two children family. So if you have a family history where mom and dad were single children and they only have one child per family, that's a very small family size. And so a genetic mutation which is present may not have expressed itself. So it is very important that you stay attuned to all of these issues when you get a detailed family history. So any history of breast, colorectal, ovarian, prostate, male breast cancer, all you need is one male breast cancer or one ovarian cancer in the family for that family to be tested or that particular individual to be tested. As you know, pancreatic cancer is part of a BRCA2 family as well. These are the pathogenic mutations that were identified in Indian patients, specifically BRCA1 and BRCA2. And based on this study, there appears to be a higher incidence of BRCA2 in Indian patients as opposed to Caucasian and other populations. So who should you test or who should you recommend genetic testing to? There are multiple guidelines. It's almost impossible for anybody to remember those guidelines. But as a rule of thumb, the things that I think about when I'm thinking of a genetic cancer syndrome is anybody who's been diagnosed with any kind of inheritable cancer below the age of 40 to 50. And that's 40 to 50 is sort of your rule of thumb. Less than 40 for sure. Even if one family member is diagnosed, that person needs genetic testing. Any family that has breast, ovarian, uterine, colon, pancreatic, prostate, or melanoma, because they're all part of the BRCA syndrome or Lynch syndrome. Leaf-Romani includes leukemias, osteosarcomas. So think about those kind of rarer cancers in the family. You have to start thinking about Leaf-Romani syndrome. Anybody who's been diagnosed between the ages of 46 to 50 who has other family members with any of the cancers that I mentioned about. Triple negative breast cancer. So triple negative breast cancer is a type of histology and receptor status where these patients are not sensitive to estrogen or progesterone-based therapy or HER2-based therapy. Triple negative breast cancer tends to have a very aggressive prognosis and has a significant association with genetic cancer syndromes, especially BRCA syndrome. So it's very important if a person has triple negative breast cancer, that person gets referred to genetic testing or genetic counseling. I think it would be less of an issue in India, but if there are Ashkenazi Jewish patients, so fair-skinned Jewish patients, they have a higher risk of what we call founder mutations. So even if there's no family history of cancer, a person of Ashkenazi Jewish ancestry should be referred for genetic testing. Today, all patients with pancreatic cancer, can the moderator mute, please, the rest of the people? So all patients with pancreatic cancer by themselves, just one person with pancreatic cancer is an indication for germline genetic testing. Now, when we come to the subtypes of breast cancer, the two most common subtypes are invasive ductal and invasive lobular. So when you remember the anatomy of the breast is made up predominantly of fatty tissue. In the breast, we have lobules that make milk and hormones related to breast function. And then you have ducts that carry the hormones and the milk to the nipple. Cancer can arise either in the lobule, which look like grape-like clusters, or in the ducts. As long as they are within the membrane of the lobule or the duct, they are called carcinoma in situ or non-invasive cancer. This does not tend to spread to other parts of the body. LCIS, which is lobular carcinoma in situ, is a harbinger of bilateral breast cancer. So if you have LCIS in one breast, there is no reason to remove that LCIS because that patient is at risk for bilateral breast cancer. So that person is a candidate for endocrine therapy to decrease the risk of invasive breast cancer and future non-invasive breast cancer in the ipsilateral and the contralateral breast. If the person has DCIS, ductal carcinoma in situ, that's a totally different disease. That's considered stage 0 or non-invasive cancer. DCIS needs to be removed by a lumpectomy followed by radiation. DCIS patients can either be hormone sensitive or hormone insensitive. Patients who have estrogen or progesterone positive tumors are then treated with anti-estrogen therapy. Anti-estrogen therapy can be tamoxifen, whether it's a pre or a postmenopausal patient, because tamoxifen works regardless of menopausal status. If it's a postmenopausal patient, you could use aromatase inhibitors. Aromatase inhibitors are drugs like anastrozole, letrozole, exemestane, which block the enzyme aromatase, and they only function in women whose ovaries have either been ablated or who are postmenopausal. And the way aromatase inhibitors work is our body produces estrogen in the ovaries, the adrenal gland, and in the fatty tissue. Ovarian estrogen production is the main source of estrogen in the body. So when you become postmenopausal, you still have a small amount of estrogen in the adrenal glands as well as in the fatty tissue, which the aromatase inhibitors can block. Tamoxifen, on the other hand, is a selective estrogen receptor modulator. So it is selective because in the breast, it's an anti-estrogen, but in the uterus, it's a pro-estrogen, hence the increased risk of uterine cancer. In the blood vessels, it's a pro-estrogen, so it increases the incidence of DVT, PEs, and strokes. In the bones, it's a pro-estrogen. So as opposed to aromatase inhibitors that increase the risk of osteoporosis, tamoxifen decreases the risk of osteoporosis. So when you look at infiltrating or invasive ductal cancer versus lobular cancer, 80 to 85% of patients tend to have ductal carcinoma, invasive ductal carcinoma, and 10 to 15% tend to have invasive lobular carcinoma. And then you have colloid, medullary carcinoma, which are very rare subtypes. 75% of these invasive cancers are hormone sensitive. 15 to 30% are HER2 amplified, and triple negative breast cancers may account for up to 31% of breast cancers. So today, breast cancers are no longer classified just as hormone positive, HER2 negative. We've moved on to what's called the molecular subclassification. We now classify a breast cancer into luminal type A, luminal type B, HER2 amplified, and triple negative based on molecular profiling of the cancer, which is a much more accurate way of assessing what the clinical behavior of this cancer is likely to be and what treatments these patients may respond to. So just like I talked about, that is the molecular subtyping of cancer. We've moved away from just traditional histology and hormone sensitivity. There are stage 1, 2, 3, and 4, like all cancers. But when I like to conceptualize treatment options, I like to think of cancers as localized, locally advanced, and metastatic, because it becomes easy to explain to the patient. As you know, today, multimodality treatment of breast cancer is the norm. We use surgery. Patients benefit from radiation. There's estrogen therapy, HER2 therapy. There are anti-androgen therapies that we're using for metastatic cancer. There are lots of other targeted therapies and immunotherapies that we use today, depending on the stage of the cancer. We'll be touching base on some of them. So hormone-sensitive breast cancer, we talked about tamoxifen. Toramephin and raloxifene are not approved for invasive cancer. Raloxifene is approved for DCIS, LCIS, or for chemoprophylaxis. Raloxifene, as you know, is not chemotherapy. It's a selective estrogen receptor modulator. So if a woman has atypical ductal hyperplasia, atypical lobular hyperplasia, or LCIS, which are precancerous conditions, you can use tamoxifen, raloxifene, or aromatase inhibitors. On the other hand, if a woman has invasive breast cancer, you cannot use raloxifene because it's not approved. The advantage of raloxifene over tamoxifen was a STAR trial that showed there was a decreased incidence of uterine cancer, DVTs, and PEs. Aromatase inhibitors, like I talked about, are used in postmenopausal patients. In metastatic patients, there is a class of drugs called selective estrogen receptor downregulators. Fulvestrant is one of those examples, and we also touched base on androgens based on androgen receptor status in metastatic breast cancer. Now, HER2 is a family, an EGFR receptor. It's a family of receptors. There's HER1, HER2, and HER3, which actually constitute a very aggressive form of breast cancer. So it is very important we recognize whether that patient who has breast cancer is ER or PR positive, because we can use hormones to manipulate their cancer if they're ER or PR sensitive. And if they are HER2 positive, it is critical that we use anti-HER2 antibodies. Because in the past, when we did not know about HER2 or we did not have HER2 antibodies, these patients had a very high risk of reoccurrence between 2 to 5 years after treatment, and majority of women died from brain mets. The behavior of untreated HER2 positive cancer tends to be one where there's a very rapid reoccurrence and metastatic potential, and CNS sites tend to be one of the highest sites of metastatic disease. Thankfully, today we have a lot of anti-HER2 antibodies and newer therapies, including antibody-dependent conjugates. We have oral tyrosine kinase inhibitors that prevent the HER2 pathway. So this is a slide that talks about how the HER2 pathway then affects downstream pathway like your MAP kinase, your PI3 kinase, AKT, mTOR, which is the mammalian target of rapamycin. So multiple downstream pathways are activated by this HER2 mechanism, which leads to transcription and downstream cellular effects. So HER2 positive cancers tend to be aggressive because they cause so many downstream cellular changes that increases multiplication of cancer cells, decreases apoptosis or programmed cell death, and increases metastatic potential. So by blocking the HER1, HER2, and HER3 pathway, we have made tremendous progress in treatment of HER2 positive breast cancer and improvement in cure rates. So I've put out trastuzumab, which is Herceptin, pertuzumab or Perjeta. TDM1 is adotrastuzumab emtansine, which is an ADCC. So antibody drug dependent conjugate is a relatively, I would say, newer mechanism in oncology where the chemotherapy drug is bound to an antibody. This antibody has a specific target antigen or target protein in the cancer cell. So rather than attacking the good and the bad cells, which is what chemotherapy does and is indiscriminate and causes more side effects, these antibody-dependent drug conjugates are able to attack a specific target on the cancer cell. They latch on to this specific target and then release the chemotherapy. So this ADCC pathway tends to be a lot more effective, lot less side effects, and therefore is a much better way of delivering chemotherapy in most diseases. And ADCC is now becoming a very, very rapid scientific process in multiple breast cancers and other pathways. So this is another slide showing the importance of the HER2 receptor. So when you do not have any blockage of HER2 antibodies, there's increased cancer cell survival, increased growth. But when you inhibit that pathway, the cancer cell survival is diminished and it leads to apoptosis. So this is a very busy slide, but I just wanted to make you understand that today, breast cancer is not treated in silos. So it's not that a surgeon is sitting in his office and giving a diagnosis and treatment plan, then an oncologist is doing something, and then a radiation doctor is doing something. It's a multidisciplinary approach. We talk to each other multiple times during a patient's treatment journey because breast cancer treatment is a rapidly evolving paradigm. So you need to understand the pathologist, the radiologist, everybody is an integral part of coming up with the treatment plan. So it is very important you understand the pathology of the disease. Sometimes they will give me a pathology that says, oh, patient has a grade 1 well-differentiated cancer and it's hormone negative and HER2 positive. That does not make sense because a hormone negative, HER2 positive cancer by definition is a very aggressive cancer. It should not be well differentiated. So I will call my pathology colleague and say, hey, can you look at this slide? There's something there that doesn't fit the typical criteria. And so it's very important we have this back and forth dialogue between our colleagues. Now, the other major shift that has happened in breast cancer treatment is no longer is chemotherapy the only game in town. And we don't have to use just the traditional risk factors to predict behavior. So we now do molecular profiling or genomic analysis of the cancer. So there are multiple tools that look at RT-PCR. So there's Oncotype, there's MammaPrint. In India, you have Can Assist, which is a homegrown tool, which was developed by a lab in Bangalore that will help assess in an estrogen positive, HER2 negative patient, what is the risk of recurrence systemically, which means distant recurrence over the next 5 years. If the risk of recurrence is low, that patient does not need chemotherapy. So up to 5 centimeters of breast cancer and less than 4 lymph nodes, today we're able to avoid chemotherapy in a majority of patients. So this is called tailored treatment or precision medicine. You're not using statistics alone to treat the patient. You're able to tailor the treatment of the cancer to the patient's cancer and cancer characteristics. So for example, MammaPrint, like Can Assist, can separate patients into low risk who have a very low risk of distant metastases over the next 5 years. These patients can be treated with adjuvant endocrine therapy alone, adjuvant being after surgery. And if they have high risk of reoccurrence, these patients need chemotherapy in addition to endocrine therapy. That brings us the question, so what is the benefit of these precision tools? So this is a very important pie chart that I want you to focus on. So in about 46.7% of patients, traditional risk factors tell us that that person does not require chemotherapy. And MammaPrint confirms it. So there's concordance between traditional risk factors and genomic analysis. In about 14% of patients, we were telling them they needed chemotherapy, and now MammaPrint has shown us that those patients don't need chemotherapy. So about 15% of patients who otherwise would have received chemotherapy are able to avoid chemotherapy and all the downstream side effects. When you come to the third gray box, 15.1% of patients we thought were low risk based on traditional risk factors, and we thought they did not require chemotherapy. Actually, when we look at their molecular profiling, turn out to be high risk. So in 30% of women, by doing molecular testing, you're changing the treatment options. So 1 in 3 women will change the treatment based on molecular profiling. So it's very important when you get into oncology or you have a family member or a friend who you're counseling, if they're estrogen positive, HER2 negative, if they have less than 5 centimeters of primary breast tumor or less than 4 lymph nodes, you ask the oncologist, what is their molecular risk? And if they have not performed, you insist that you understand their molecular behavior. So 70% of women with early stage estrogen positive breast cancer today do not require chemotherapy, which is a huge, huge benefit for the patient. We are also able to tailor the duration of treatments. So historically, we were telling women they needed tamoxifen for 5 years. That changed about 4 years ago when a large study confirmed that 10 years of tamoxifen was better than 5. We now know that aromatase inhibitors should be given for a minimum of 5 years, and 1 in 10 women may benefit from continuing it for an additional 5 years. So we have a tool called Breast Cancer Index where we can test the patient's tumor sample, and we're able to assess what is the risk of late recurrence and what is the benefit of continuing hormonal therapy past that traditional mark. So what you're doing is you're able to stop therapy at the 5-year mark for patients who do not need it past 5 years. Therefore, you're avoiding side effects, avoiding unnecessary financial burden. But in that 1 out of 10 women that needs that extended endocrine therapy, you're able to prove as to why they need that extended therapy. So this is again Breast Cancer Index, which identifies women into low, intermediate, and high risk, and it's able to predict whether they will benefit from endocrine therapy. So chemotherapy is used for lymph node positive patients, but today it's not used for all lymph node positive patients. If you have 4 or more lymph nodes, and we know that pre-op, that patient would benefit from chemotherapy. But if they have less than 4 lymph nodes, Then we would do the molecular or genomic assay and would only treat them if they have high-risk breast cancer. All HER2-positive breast cancers and triple-negative breast cancers, which are over 5 millimeters, 5 millimeters, not 5 centimeters, because they tend to be very aggressive and have a very high chance of systemic spread. These patients need chemotherapy for triple-negative and chemo and anti-HER2 antibodies for HER2-positive disease. Every woman with inflammatory breast cancer requires multimodality treatment. Inflammatory breast cancer goes unrecognized for many, many months. It's very important you understand breast cancer can present without a mass. It can present with breast pain. These women have classic cellulitis-like pictures. It occurs more commonly in postpartum women as well, and very often is mistaken for lactation mastitis. These women are treated with multiple courses of antibiotics before finally somebody says, go get a second opinion. And when you examine the person, she has redness, she has very engorged breasts, peau d'orange, dimpling of the skin, and doing a skin punch biopsy, even if there is no mass to biopsy, will give us a diagnosis of inflammatory breast cancer. There are multiple different chemotherapies. Remember, adriamycin is still the backbone of chemotherapy in a few types of breast cancer, not necessarily all. Adriamycin can cause dose-dependent cardiomyopathy, and that cardiomyopathy is a lifetime risk. It does not happen necessarily during chemotherapy. So if anybody received anthracycline-based chemotherapy, even few years prior to you seeing them, and they now have new onset cardiomyopathy, remember anthracyclines can cause cardiomyopathy. Anti-HER2 antibodies like pertuzumab and trastuzumab can cause transient myocardial suppression. So we monitor their echocardiogram. If they have decreased myocardial contractility, we stop the drugs. And then once their myocardial function improves, we can re-challenge them. This is not permanent myocardial damage, it's transient myocardial dysfunction. So between neoadjuvant, which is pre-surgical, and adjuvant, which is post-surgical, what are the benefits? Breast conservation therapy is more common when you give them neoadjuvant chemo, better cosmesis, pathological complete response. So this is a very important surrogate marker. When a woman is given chemotherapy, and after that, she goes to surgery. If at the time of the surgery, majority or all cancer cells are no longer viable, that person is said to be in path CR. Path CR correlates directly to improved disease-free survival and overall survival. However, women who do not accomplish path CR are now eligible for additional treatments, which will improve their chance of cure. So in every woman who needs chemotherapy today, we assess and see, is there a benefit to waiting after surgery? If not, all these women are treated up front. So it's very important that medical oncologist and the surgeon talk ahead of time. So it's used, neoadjuvant chemotherapy is used for lymph nodes more than 4 or high-risk genomic assay scores, HER2 positive, triple negative, anytime you want to downstage the disease. If there's chest wall involvement, if the cancer is eroding close to the skin and the person wants to have a lumpectomy, you want to downstage the disease so you can get negative margins. All patients with inflammatory breast cancer require neoadjuvant chemotherapy. When the person is HER2 positive, in addition to chemotherapy, we use neoadjuvant HER2 antibodies. We can also use neoadjuvant endocrine therapy. You don't have to always use chemotherapy to downstage disease. If a person is strongly estrogen or progesterone positive and is HER2 negative, that person can be treated with aromatase inhibitors or tamoxifen to shrink the cancer. It may take 6 to 9 months, but if you're not looking for complete shrinkage, and if there's partial response and the patient can have effective oncological surgery, you can use endocrine therapy to shrink the disease. Advantages of neoadjuvant therapy is reduction in tumor burden, downstaging of lymph nodes, early assessment of tumor response. So when a woman gets chemo after surgery, how are you going to know if that was the right chemo for that person? You don't. You're basing it on the previous studies. But when you give it to her neoadjuvant or before surgery, you have a tumor mass that you can measure. And as the mass shrinks, you and the patient get extreme confidence that this is the right chemotherapy for that patient. Obviously, you will assess the tumor pathologically at the time of surgery as well. The next few slides I'm going to run through, they just show that path-CR is associated with an increased disease-free survival, regardless of whether it's ER/PR positive, HER2 positive, or triple negative breast cancer, and it directly correlates with better overall survival. There are grades of path-CR, so it's very important the pathologist knows that this woman received neoadjuvant therapy when he's reviewing the pathology, so he can grade the response, because depending on what the response was, it correlates with better survival if the response is better. And you don't have to be a rocket scientist to know if chemo or endocrine therapy killed 85 to 90% of the cells, and there were only 10 to 15% viable cells, those patients tend to do better, as opposed to a person whose cancer responded less than 10% to chemotherapy. So if there's residual disease after neoadjuvant chemotherapy, you can use other modalities. So for triple negative breast cancer, there's an oral chemo called capecitabine, which is a prodrug of 5-fluorouracil. When a person does not undergo path-CR and she's a triple negative breast cancer, giving capecitabine post-op decreases the risk of recurrence by another 20%. So every one of those increments will translate to better survival, prolonged disease-free survival in that patient. If it's a HER2 positive patient, then you stop the pertuzumab and the trastuzumab and switch them to adotrastuzumab, which will further improve their chance. So distant recurrence goes down from 15.9% to 10.5%. 3-year disease-free survival goes up from 77% to close to 90%. So this is Catherine, which is a study that showed a woman who's got HER2 positive cancer who doesn't have a complete response. Switching therapies makes a difference. Same with CREATE-X study. There are lots of newer HER2 molecules that are now being approved. Enhertu is one such molecule. Destiny trial showed that the objective response rate in patients who were heavily pretreated with metastatic HER2 positive cancer still had an objective response rate, overall response rate of 45%. That's tremendous. When you're talking about patients who've already had a couple of lines of therapy in an aggressive cancer like HER2 positive breast cancer, a 45% response rate, it translates to a significant response rate. Tucatinib is another newer molecule. Tucatinib has shown activity even in patients with brain mets. Response rates with tucatinib seen on the HER2 CLIMB study were dramatic. So if you look at the 1-year progression-free survival, tucatinib had a 33% survival as opposed to just Herceptin and capecitabine, which was 12%. And this survival was also seen in patients with brain mets, which is the worst possible site of metastatic disease in breast cancer. As you know, there's a blood-brain barrier which prevents CNS penetration of many of the systemic agents. So when you have brain mets, radiation becomes the mainstay of treatment. To see 24.9% 1-year progression-free survival in HER2 positive metastatic breast cancer to the brain is tremendous. There are lots of other newer therapies. So CDK4/6 inhibitors are already used in estrogen positive breast cancer, and they've shown an improvement in survival. I've listed multiple classes of drugs which are either FDA approved or being studied in combination with others in breast cancer. Triple negative breast cancer, there is a drug called Trodelvy that got approved about, I think, February this year, which showed a dramatic response in heavily treated triple negative breast cancer, which is another very aggressive form of cancer. This is another antibody drug conjugate. Remember how we talked about lower side effects, better response rate? Trodelvy shows the same. Again, this is a slide showing the response rate and the survival with Trodelvy. So 12.1 months versus 6.7 months with traditional chemotherapy in pre-treated triple negative metastatic breast cancer. This is what triple negative breast cancer landscape is going to look like in the next few months to years. Multiple targets, looking at molecular subtyping, biological pathways, immunotherapy pathways. So the cure rates for breast cancer are definitely increasing. It is very important that we in India make sure women have access to affordable care, that we catch the disease early. We prevent the disease in women who have a strong family history. again, newer direction. This is talking about CDK4/6 inhibition. In the interest of time, I'm going to cut to the chase and talk about a couple of very important topics. So today, metastatic breast cancer, which has traditionally been looked at as an incurable cancer with a short life expectancy, we are able to look at very long survival rates in certain subsets of patients, to the point where if a woman comes in with a new diagnosis of breast cancer and you do a CAT scan and a bone scan and you find she has stage 4 breast cancer, even in that setting, some women will benefit from lumpectomy with radiation or a mastectomy. So local regional therapy in the presence of metastatic cancer is a new paradigm shift in breast cancer. This happened in colon cancer almost 10, 15 years ago in Europe, but this is really hitting the highway in breast cancer in the Western world. So just because somebody has stage 4 breast cancer does not mean it has to be a death sentence. You can prolong survival. There are potentials to put them into complete remission. And the mechanism of action is by removing that cancer stem cell, you're decreasing the tumor-induced immunosuppression, you're decreasing the metastatic potential of the cancer itself. Specific patient characteristics obviously have to be looked at. It would be malpractice to say every patient who's got stage 4 breast cancer should have local regional therapy. So we have to look at tumors grade, age of the person, differentiation, HER2 positive versus HER2 negative. Did they receive chemotherapy? Are they a candidate for chemotherapy, etc.? So breast cancer specific survival in stage 4 with or without surgery clearly shows in the right patient with stage 4 cancer, you still can operate on the primary and improve survival. Frontiers in Oncology, February 2020, published a wonderful article. You can look at it. It's available for public access. They actually looked at over 17,000 breast cancer patients and came up with a pre and a post-op nomogram that recognizes patients that would benefit from surgery. I think what is really important in India is to narrow disparity. Disparity is huge, not just based on socioeconomic strata, based on education, rural versus urban, cost of care between private and public, lack of insurance. I think social stigma is another huge topic. There are about 90% of Indian women who are breast cancer survivors have reported that they were embarrassed about the cancer and they were embarrassed to talk about the disease. 90%, and we're in 2020. So we need to educate our patients that no longer is cancer a death sentence. If it's detected early, screening, prevention, every one of those techniques will improve survival. I wanted to spend a couple of minutes on the economic impact of breast cancer, especially as it applies to India. As you know, older the woman is, there are likely to be more comorbidities, diabetes, hypertension, kidney disease, etc. That person tends to have a lot more complications from any treatment you use and therefore has higher costs. High proportion of patients have out-of-pocket, expenses. Even if they're insured, there is a study that showed 43% of cancer drugs are not covered by insurance, possibly because there's partial reimbursement. That is a huge cost burden to the person. So it is very important we try and recognize these patients in the precancerous stage or try to prevent cancer, teach them about all the health and lifestyle modifications that they can make. When you look at the 2016 Punjab report, 37% of cost of breast cancer therapy was from drugs and 27% was from hospitalization. So the earlier you find the cancer, you use fewer drugs. That's fewer cost. If they don't have to be hospitalized because they're not getting chemo, cost is going to be lowered. Low income patients struggle tremendously. Over 20% of their annual household expenditure can be spent towards a cancer budget. That's unaffordable for anybody. So again, educating them. As medical students, I would implore you, please take this upon as a personal mission to educate your friends and family. You start in a small radius, and that radius is going to multiply. Your mom will talk to 5 of her friends. Those 5 friends will talk to 5 other friends. So it's very important. You talk about the importance of breast self-exam, physician exam, mammogram. If the mammogram's negative and they still feel a palpable mass, they need to seek medical attention. No longer should people have that opinion, oh, I'm not going to see a doctor because when I go to a doctor, they find something wrong. That is not true. Doctors do not want to find something wrong with patients, but they want to help patients. 43% of Indian population struggles to meet expenses related to oncology. That's 43% of over 160,000 patients who are dying each year. Just dying. I'm not even talking about incidents. Death is 160,000. Imagine nearly 50% of them are struggling to meet their expenses, which means they're going to go into debt. We have to change that. The treatment landscape. Coming up with indigenous, homegrown, artificial intelligence, machine-based learning. CanAssist has done a phenomenal job. So CanAssist is a tool that looks at estrogen positive, HER2 negative breast cancer, and it can assess the risk of reoccurrence. What CanAssist did is they used their data and compared it to Adjuvant Online, which is a Western tool. And they were able to show that high-risk breast cancer, which was detected in 62% of patients on the Adjuvant Online tool, actually dropped down to 29%. Why? Because the majority of these tools have been only validated in the Caucasian, the African American, or the Latin American population. It does not apply to Asian women. And we know based on the Nature article that women of Northern India tend to have a different genetic makeup than women in Southern India. So having homegrown validated tools and using that to treat our indigenous population is very, very important. These additional tools come at a cost. There's no question about it. But if you can avoid chemotherapy and pay few thousands of rupees before you start chemo to understand what is your risk of recurrence, that is money well spent. So that leads to improved quality adjusted life years. We talked about CanAssist. So quality of life with breast cancer therapy today has gotten a lot better because we have very, very good supportive medicine. So nausea, less than 15% of women report significant nausea. We have something called cold cap that you can use to prevent hair loss during chemotherapy. We monitor their heart functions. We know how to educate them about nutrition, hydration, physical activity. We're able to teach them how to decrease the risk of recurrence after they've been diagnosed with their first breast cancer. So giving them appropriate educational support, family support, social support is crucial. I think I'm 4 minutes past the time. I'm sorry. Any questions?
That was a really insightful session, ma'am. I must say that, and the way you presented this huge tank of knowledge and so many easy words for us to interpret. That was really, I would say, amazing. We have some questions from our audience, as well as some. We had a WhatsApp group where we asked our audience if they had any questions. So most of them are some things that you've already covered. Except the fact that there are some people who want to know that does women's innerwear related to breast cancer, and is it good to keep wearing it at night as well?
Okay, so there is no randomized control study that shows that. So as you know, there are anecdotal data and there is scientific data. So there is no scientific data that suggests that continual wearing of innerwear makes a difference in cancer incidence.
Okay, another question, ma'am. So someone wants to ask, what is the best method to screen for breast cancer in OPD settings?
In outpatient settings, okay. I don't know what are the current recommendations in India. So here in the United States, we get a baseline mammogram at the age of 30. And then for an average risk woman, screening starts at the age of 40 and we get annual mammograms. We do not stop annual mammograms. There is no upper limit of cutoff as long as you know that person is likely to live at least 5 years from now. So we even have women in their 80s and 90s who are extremely active getting their annual mammograms. In the outpatient setting, when you are examining a patient, I think there are very important factors that you need to look at. One, get a detailed family history. Get a detailed personal history. Teach the woman to do breast self-exams. In a country where annual physical exams are an unheard thing, it is very important the woman understand her breast anatomy. Teach them changes that happen before and after menstrual periods. Tell them to examine their breast at the same time of the month. You do a physical exam as the provider, healthcare provider. That physical exam should be a breast exam, an axillary exam, and a detailed physical exam, not a cursory, oh, do you have any breast masses? You're done. Ask the person about other risk factors, alcohol, smoking, physical activity. You can use the outpatient appointment, and it doesn't take a lot of time. Believe me, you can hit multiple bullet points in less than 3 to 5 minutes to talk about improve your exercise, decrease your weight, decrease red meat intake, improve high fiber, vegetable intake. All of these are protective factors. If you're on hormonal therapy, understand that that can increase the risk of breast cancer. So talk to them about other interventions they can do other than taking hormonal pills if they can. And then talking about mammograms. So if a woman is 40 years old, talking to them about mammograms, talk about affordability, talk about getting insurance that would cover all of those. So there are multiple aspects: going through a detailed history, counseling the patient, obtaining a good family history, educating the patient about the importance of breast self-exam and compliance with follow-up, teaching them signs and symptoms of what breast cancer might feel like or look like, doing a thorough breast and axillary exam, and ordering mammograms appropriately. Those are the things you can do as a healthcare provider in the outpatient setting.
Excellent. That was really excellent. And other questions is, one of the other questions is that what could be the risk factors for breast cancer in males, and do the men population need self-breast examination?
Okay, so self-breast exam in women or men has not shown an improvement in survival. The only reason physicians continue to recommend that, especially in countries like India where people do not get annual physicals, is if you find a mass, that might be a reason why you would go see a healthcare provider. Okay, so in males, there is no reason to do monthly self-breast exams, but if they find a change in their breast, men should be made aware that they could be at risk for breast cancers. A lot of men, even in the Western world, have never heard of male breast cancer. When I mention that, their eyes pop out. So it's very important you make them aware that any change in the breast needs to be evaluated, be it a female or a male. And the risk factors, genetics is the #1 risk factor for male breast cancer. Often gynecomastia, which is bilateral, can be mistaken for a breast mass. As you know, gynecomastia can happen with cirrhosis, alcoholism, with hormonal therapy for prostate cancer. So it's important to educate men about the differential diagnoses of breast masses and breast lumps, but also informing them that every breast mass or breast lump, however small in a male or a female, absolutely needs to be evaluated. I can tell you numerous instances in women in India who've called me, friends and family, and said, oh yeah, I had a breast lump 3 months ago. I hit my breast against the door. I thought it was a scar. I thought it was blood. I thought it was a hematoma. Sure enough, 3 to 6 months later, they have cancer in their breast, and that could have been picked up early. So education, 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 awareness. I cannot overstate the importance of those.
Absolutely, ma'am. Absolutely. You just can't do anything if there's no awareness. And that was like a very good, I would say, a take-home session for everyone here, that if you are educated enough, you're fortunate enough that you have the means to get to that education and the awareness sessions like we're doing some today with such great luminaries today, you should spread it. One of the other questions is, Does lifestyle diseases like PCOS play an important role in breast cancer? And if yes, then how to prevent breast cancer in a PCOS patient who is on HRD?
Okay, so remember, we do not understand all the risk factors associated with breast cancer. So just because a woman has higher estrogen exposure, either due to PCOS, early menarche, late menopause, age at first live birth over 30, no breastfeeding, not all of those women develop breast cancer. So you can only modify the risks that you can modify, right? If you need to be on hormone replacement therapy because medically it's necessary, or oral contraceptive therapy for PCOS, which is medically necessary, you can't alter that, but you can alter all the other risk factors. So understand your family history, maintain a very healthy lifestyle, what you eat, how often you exercise, your body mass index, avoid smoking, avoid drinking alcohol more than 3 to 5 drinks a week. So looking at all the other lifestyle modifications, because we know if you look at the traditional textbooks on cancer, we always talk about the second hit hypothesis. I don't think it's just the second hit. There are multiple hits before a male or a female goes on to develop cancer. How do we know that? People who have an abnormal gene that is associated with cancer do not have 100% incidence of cancer in that particular genetic mutation line. The risk is between 50, 30, or 80%. So there are other protective factors that prevent that genetic mutation from converting a normal cell into a cancer cell and then multiplying indiscriminately. So I cannot stress the importance of lifestyle. One of the things that all of us have noticed when we come to India every year, lifestyle has changed for the worse in the urban population. In the name of westernization and urbanization, people's body mass index has gone up, their waist to hip ratio has gone up. Traditional healthy diets have been replaced by very, very unhealthy diets. Meat consumption, eating fatty foods, lack of exercise, not going to see a physician. All of these are very, very important in normal health and maintenance, not just breast cancer. So healthy living has been associated with the decreased incidence of colon cancer, not to mention heart disease and stroke. So for overall benefit, I think fitness and eating healthy can always be two pillars of what we can do to decrease any health issues.
Thank you, ma'am. Thank you for the information. One of the questions is that how can breast cancer be avoided or prevented in transgender women?
In transgender women, again,
yes,
understanding, are they being given estrogen? Is it combined estrogen progesterone, or is it unopposed estrogen? What is their family history? Breast self-exam and physician exam. So all of the characteristics that we just talked about applies to transgender women as well.
Okay. One of the other questions is, what should women who don't have adequate resources and time for breast examination at hospitals do? As many women still lack the basic knowledge about this, and what steps do you think government should take in this?
Okay, so I didn't understand the first part, so let me repeat it. So you're asking, what should women do if they don't have time and education to do breast exams?
It says, what should women do who don't have the adequate resources and time? Yes.
Okay, so there is no excuse for lack of time. Okay,
True.
I will never, ever subscribe to the view that you don't have time, maybe less than 5 minutes in a 24-hour period once a month to do breast self-exam. Not an option. Definitely lack of education and resources. I think the government absolutely can do a lot, which is I think we have one of the most successful THC, Anganwadi, so many other government sponsored programs where we are in touch with women at grassroots level. So using these female social workers and male social workers, I don't think gender today is any, has any impact, but if it does, using the appropriate resources at the grassroots level. So rather than treating disease, physicians and healthcare should start looking at wellness, well-being, and prevention. That's when people will start trusting healthcare rather than telling them, come and see me if you have this, this, and this. I would behoove you medical students to start working with your universities, set up small camps, do it as part of your preventive and social medicine. Take a village and take just 5 things you're going to teach them over the next 5 years. Importance of breastfeeding, communicable diseases, heart disease, prevention and detection of cancer, and hygiene. Can you imagine how much of an improvement we as a country would do in the next 5 years if every medical student did a small drop of what they could do in this ocean? We can change the landscape of Indian health and well-being. There will no longer be uneducated. There might be illiterate people, but they don't have to be uneducated. Indian men and women have for the longest been known to have a very high degree of native intelligence. Let's not dumb them down. If they're given the appropriate opportunity, every one of them will be able to take their health and well-being into their hands.
Thank you, ma'am. There is a short, I would say, a case scenario which one of the participants has sent. It says that if a mother who comes to you who's pregnant and she comes to you with breast cancer in the 4th month of pregnancy, what to do?
Okay, so it's a very important point, how to treat breast cancer during pregnancy. So as you know, the first trimester is the most important trimester where there is organogenesis. So we treat women during the 2nd and 3rd trimesters with chemotherapy. We're able to safely get them through their pregnancy and through term. If we do need to do surgery, which is often the case in early stage breast cancer, because these women cannot go through radiation, they many of them choose to have a mastectomy. It's easier when they're diagnosed in the latter part of their 2nd or 3rd trimester, because usually giving them endocrine therapy or chemotherapy, well, we can't give endocrine therapy during pregnancy, I take that back. Giving them chemotherapy can help them get to their full term. Sometimes we may have them deliver a few weeks prematurely, so we do not delay their cancer care. It depends on the stage of the cancer, depends on the hormone, HER2 positivity, the grade of the cancer, and where they are. But we can safely get women through pregnancy. They deliver normal children. Similarly, women who've been treated with breast cancer can go on to have normal fertility, because we do have fertility preservation techniques, and then go on to have normal children.
Thank you, ma'am. I think that was like really, really insightful, and something that, you know, both the gynecologists and the oncologists working together. Thank you so much for this, for your information. These were the questions that we had from online. Now I'd like to hand over to my, yes.
Somebody going to do the questions in the chat?
Yes, I'd like to hand it over to my assistant director, Salekia, to handle the questions from the chat box.
I think you're muted.
Hi, ma'am.
Hi.
My name is Lekia. I'm the Assistant Director for SRE SOT. Thank you for being with us today. It was such an enlightenment session. It was amazing to be with you. I've learned a lot today from you. I guess I've never learned this much in my education during MBBS also. So, ma'am, we got a question here saying, What if a patient has a family history of breast cancer and is BRCA gene positive? How should we further proceed, and should we remove her breast as a prophylaxis?
Okay, so if the family history is positive, the first thing I would do is test that person, right? So if a mother has a BRCA gene, the chance of her giving it to her offspring is only 50%. So if the person you're talking about has a BRCA gene, there are multiple techniques you can do for prevention. One, you need to understand where she is in her reproductive stage, right? If this is a woman who's 20, who's not yet married, who doesn't have children, you don't want to talk about a prophylactic mastectomy. So in those women, what we do is we do mammograms alternating with MRIs, starting very early. So what it would look like is we would do annual mammograms and then annual MRIs, which are 6 months removed. And what we are trying to do is detect cancer early or detect it when it's in the precancerous stage. Why do we do mammograms alternating with MRIs? These younger women tend to have dense breast tissue, so mammogram may be false negative. Also, MRIs pick up those interval cancers. So if they are still in a stage where they cannot have a bilateral prophylactic mastectomy, or they don't want to have a bilateral prophylactic mastectomy, one is monitoring them with appropriate surveillance. It's not screening anymore. You're surveying the patient for cancer, because depending on what gene they have, they can have between a 30 to 80% chance of developing cancer in their lifetime. Second is if the woman is able to, which means she's not pregnant, if there are no contraindications, they can go on tamoxifen. Tamoxifen is used for prophylaxis of breast cancer in patients with genetic mutations. Third is not everybody who even has cancer and has a BRCA mutation needs to have a bilateral mastectomy. They may choose to retain their breast, but they may choose to undergo more frequent surveillance techniques. So bilateral prophylactic mastectomy is one option, but the spectrum goes all the way to keeping the breast and just making sure you're monitoring them more often. They should understand the risk and putting them on medications for 5 years, which will decrease their future risk.
Thank you, ma'am. That was amazing. And we also have a question saying, a lot of people in Indian rural areas cannot afford chemo. So is there any other option that we can take, like anything we could prevent from home or something like that?
So first, I think understanding that majority of women today do not require chemotherapy, right? 70% of estrogen positive women do not require chemotherapy. They can be treated with anti-estrogen therapy. Chemotherapy itself, depending on which chemo we use, is not very expensive, because majority of these drugs have been around for 50, 60 years. The newer drugs are definitely more expensive. But there are so many good government oncology hospitals or public hospitals or so-called government hospitals which have an oncology department. I think making sure that the quality of care there is of the highest caliber, as good as a private hospital. I can tell you from personal experience, there are numerous women whose parents were visiting them in the US, have been diagnosed with breast cancer. They've gone back home and they have been treated at government hospitals with the same standards that would be used across the globe. They have had cutting edge medications. One of the problems I see is inappropriate allocation of funds. And I know this is not a political discussion. This is not meant to be a political discussion, but looking at appropriate allocation of funds to make sure there is uniform accessibility to healthcare, regardless of socioeconomic status, regardless of where we come, is something that all of us are obligated to do. I think we need to get involved in healthcare policy development at the local level, so we can make sure every man and woman can get the best treatment. India is no longer a third world country. I mean, there's enough money in India. There are numerous philanthropic institutions that are willing to give millions of dollars, not millions of rupees. Making sure your patients get that access to the right hospital, to the right doctors, that's important.
Thank you, ma'am. That was amazing. So it was really nice meeting you. I would like to hand over the session to my NO, Ananya. She will be asking a few more questions that we got.
Thank you.
This is Lokesh Idar. I'd like to ask one question, Savitha. There's so much volume of the patients, oncology. There are 3 years MD internal medicine, general medicine they have. Kids want postgraduate seats. And MD pulmonology there in India, MD radiation oncology there. Can't we have 3 years or maybe 4 years medical oncology and reserve the DM for more higher oncology, higher thing like maybe a transplant or something? What is your opinion? This may solve the disease burden and also the volume and of the doctor's supply and also the need of children, students. Can you comment on that?
I think we need to look at an alternative mechanism of delivering cancer care because very soon at the rate at which at least breast cancer is growing, it will become unsustainable. People who don't have the necessary training may end up treating patients just because of lack of resources. So I think at a policy level, the government should, and they are. I mean, we had that lecture about changing medical curriculum. I think the government is looking at it, but those changes need to happen sooner than later, and they should be sweeping across the country.
So what we will do is another study with James and youngsters. They can able to take up one people and will help them the supply and need and education, medical oncology, MD 3 years, our proposal with evidence based from America, oncology from your group, our group, and data, and then present the proposal to the NMC.
Mm-hmm.
Yeah, okay, thank you. Go ahead. Next, go ahead, please, Sulakia, go ahead. Sorry.
Thank you, sir. Thank you so much for the question. And then Ananya, can you take it over? Looks like, I'm sorry, Ananya isn't here. Bhavya?
No worries, I'll do the bidding. So ma'am, we just have 2 questions from the YouTube channel that says, does enlightenment in the lymph nodes or cysts lead to hypercholesterolemia?
Does enlightenment? I'm sorry, I didn't catch that.
I feel that maybe the person's referring to metastasis in the lymph node or the cyst could lead to hypercholesterolemia.
No. There's no association. Hypercholesterolemia. Some of the drugs we use, like anastrozole, can increase cholesterol levels, like aromatase inhibitors, but no, metastases has not been associated with an increase in cholesterol or lipid profiles.
Okay. The other question says that how do younger patients usually present with more aggressive cancer as compared to the older patients?
How or why?
The person says
how. Do they
how.
present or why do they present? Okay, let me address both.
The person wants to ask how, but you can...
I'll address both. So one of the reasons why they present with more aggressive disease is younger women tend to have dense breast tissue, like I mentioned, and therefore it's harder to palpate a lump, harder for a mammogram to pick a lump, and it's not unusual even when a woman has a palpable lump. If the mammogram does not pick it up, they don't get an ultrasound, they don't get an excision biopsy or even a needle biopsy. So it's important that women understand when they're younger, breast self-exams are important. If they feel a lump, immediately seek attention, even if the mammogram is negative or inconclusive, get a biopsy to make sure you're not missing breast cancer. Number 2, I think education and awareness, I would definitely go back to that. A lot of people think breast cancer is a disease of the elderly. No longer true. I think I showed enough information. And why do they present with more aggressive breast cancer? Because the breast cancer in younger women traditionally tends to be more often hormone insensitive. Not always the case. There are plenty of young women who have hormone sensitive cancer, but there is a higher incidence of hormone insensitive breast cancer, which historically is a more aggressive cancer. And they also tend to have more advanced stage of disease just because they were not able to palpate the lump or the lump was missed on a mammogram. So there's a question by Hariharan, which says, why is there a higher incidence of breast cancer in developed countries? I think, Hariharan, you may have missed the initial part of my presentation. So one of the banes of Western society or, advanced society is the type of food intake. It is not the healthiest. So that's one of the problems. Also, decreased physical activity, depending on where you live. Number of people who exercise on a regular basis, that's lower. Body mass index, waist to hip ratio, and fat content has been associated with an increased incidence of breast cancer. High red meat intake has clearly been associated with numerous cancers. Smoking and alcohol intake, which typically alcohol intake, at least in the Western countries, tends to be more of an affluent society choice. But again, it doesn't have to be. Those are clearly associated with an increased incidence of breast cancer. So multiple reasons why affluent societies have a higher incidence, but their mortalities are improving because they have better medical services.
Thank
And
you.
Thank you,
that's
ma'am.
why the natural history of breast cancer is changing in India. That's why we have a higher incidence of breast cancer in urban cities now, because of more urbanization and a more Western-like lifestyle and food habits.
Ma'am, we have just one scenario left that says that if the father is diagnosed with colorectal cancer at 6 years of age, what are the chances for his female child to have breast cancer when she grows up?
Okay, so again, with genetic mutation, it is not just one person in the family with colorectal cancer. So those one person diagnoses are only at this time ovarian, triple negative breast cancer, and pancreatic cancer. Okay, or a woman who was diagnosed less than 40 years of age, or another family member with some cancer that you expect in a more elderly age, but was diagnosed really early. So a 65-year-old with colorectal cancer, that does not appear to be a genetic cancer syndrome. That's the average age of colorectal carcinoma. What is important is understanding what other family members had. Did they have uterine cancer? Because that would be part of a Lynch syndrome. So all of a sudden, if you said the dad had colorectal at 66 and a paternal aunt or a paternal grandmother had uterine cancer, I'm thinking Lynch syndrome. If you said a paternal uncle had colon cancer at 70, I'm again thinking Lynch syndrome. So understanding the full family history, just one person at the appropriate age, less likely to be genetic cancer syndrome. There's a question about mammogram being better than PET-CT, and I think we should address it. So PET-CT is not recommended for any stage of breast cancer, except in a very small subset of stage 4 breast cancers. One of the problems in countries like India, where there's a lot of private medical care, is techniques that are not necessarily approved for that stage tend to get used. Currently, for screening, mammogram is the #1 tool. There is no role for PET-CT in screening for breast cancer. Once a person is diagnosed with breast cancer, there may be a role, underline may be a role, to look for metastatic disease. Home remedies that one can do day to day. I think you brought it up, Sulekhya. There is no home remedy for chemotherapy. Okay, but there are a lot of home remedies that are part of improving your immune system. But what women and men need to understand is some of them can actually counteract and decrease the benefits of chemotherapy and radiation. For instance, radiation damage happens with antioxidant damage. If you take a high amount of oxidants, then and free radicals, substances that produce oxidant and free radicals, then you are going to offset the benefit of radiation. It's actually the other way. Radiation causes oxidative damage. So taking antioxidants can decrease the benefits of radiation. So high doses of vitamins, certain herbal supplements, we actually encourage our patients to bring us all the supplements that they're taking so we can advise them which ones are safe during chemo, during radiation.
Thank you, ma'am. There is another question here that says that what is the chance of grandchildren getting breast cancer if great-grandmother had breast cancer?
Again, family history, family history, family history, family history, okay? Just one great-grandmother getting breast cancer is not a risk factor. But if you told me that great-grandmother died at 30 or 40 because of breast cancer, that's a problem. She should not have gotten it that early. So if it's one person in the family who's not young and there are no other family members that were diagnosed and they don't have triple negative breast cancer, this person didn't have pancreatic cancer or other cancers, then there is no reason for the great-grandchild to worry about. Okay, see, these are questions that bring out the importance of a detailed family history. I can't tell you the number of times I ask patients and they tell me, Dr. B, absolutely no, my family, everybody's fine. The next appointment, they'll come to me and they'll say, Dr. Balaraman, I am shocked. There were so many cousins who had breast cancer. They hadn't talked to me about it. I had no idea. So that's why it's important for families to at least share information about these very important family histories.
Thank you, ma'am. I think that was it with the questions that we had today. And I just want that if, our president could say a few words.
Yeah, firstly, I would like to thank Dr. Savitha, ma'am, who took out time from her busy schedule. And also sorry, ma'am, for some late demands that we posed to you. Like it was a bit tough for you. It might have been tough for you to adjust at the last moment. And definitely we are looking forward to hosting you for more of such sessions. Like it was truly amazing. And I think if you just go through the YouTube chats, like everyone just loved it. And we got like tremendous great reviews for this session. We are just looking forward to hosting you again very soon.
Thank
and
you.
Definitely that time we will post you in much advance.
And continue doing the phenomenal work that you're doing. It's amazing to see young blood get so involved so early in the game.
Savitha, this is Lokesh. Your impression on the students' participation from India, what is your feeling?
Come again, Dr. Daro? I didn't hear you.
Your impression on the students from India, their participation. What is your opinion?
I have never ever thought they're less than any other student all over the world. I mean, I'm still hardcore Indian at heart, and I think our education system, there is room for improvement, but you guys are doing phenomenally well. The questions that were asked were very appropriate. I was very impressed with the transgender question, I have to be honest. Whoever put that, thank you, because
I put that.
Okay, good. Bhavya, that is very important because that's a subset of population that often gets marginalized, many times unintentionally. So it's very important that they also are part of the whole spectrum of medical care. So thank you again for bringing it up.
Yeah, the questions are amazing. Questions are amazing, more than our CME or tumor board. And I'm so proud and learn every day something from our kids. I'm really, really proud of that. Thank you.
Thank you, sir. I'd just like to mention, and like on the behalf of the whole TRESOC committee and the GAIMS committee, that I can just imagine that, ma'am, it's like 6 or 7 a.m. in the morning, United States, and we've been like, if you ask me, I'm a person, I don't wake up early in the morning, and it's like so commendable to, you being waking up early for us and taking such a great session with so much insightful knowledge made into so easy words for us to understand it. That's like literally like it's applaudable. And I'd also like to thank Dr. Lokesh Adara, who is the chairman for Global Medical Education Committee for AAPI. And he's also the co-founder for GAIMS. And he'd been throughout the whole course of this breast cancer awareness program. He'd been there, he'd been motivating us. And huge thanks to both of you, and thank you, Mom. Thank you, sir, for supporting us and taking such a great session today.
Fantastic. You guys are the future. So don't ever underplay your importance. You guys are truly the future, not just of India, but the world. There's so much potential, and I see so much talent. Just keep going and blazing new paths.
Thank you, Mom. Thank you for your kind words. I think we can have, like, before we bid adieu, maybe we can have like a short group picture of all of us together.
Okay.
Okay, I'll just take on the count of 3. 3.
Yeah, Bhavya, like you can just request others also to turn on their videos. Like
Yes. Yes, if the audience could just turn over their webcam so that we can have a cute little picture. Like, could see people coming up.
I don't know that you can take a group picture. See, Savitha, we're learning every day something.
When we stop learning, it's time to check out, Dr. Adara.
Yeah.
I think we can have it now. So on the count of 3, I'll ask you guys to pose or smile or do whatever you want to do.
Put some light on your room too, Bhavya.
So 3, 2, and okay, I have it. So I think that was the end of the session, and I'd everyone to please fill in the post-event questionnaire that we have put it over here, over YouTube channels and over the WhatsApp groups as well.